Okay, let's get started. So an overview of what I'm going to say. We are going to look at the theory of quantitative SPECT. Then we will go on to some practical considerations. Then we'll look at the application of standardization of multi-center trials. Then we'll look at some clinical applications, both diagnostic and for radionuclide therapy response monitoring, as well as then voxel dosimetry briefly at the end. So firstly, theory of quantitative SPECT. So Hermes SUV SPECT allows you to reconstruct SPECT data from any camera and any radionuclide and get the voxel values out in becquerels per mil or in SUV. Now, to be confident that we have accurately represented the activity distribution in the patient, we need to use a reconstruction algorithm with accuracy compensations. So we're looking at CT attenuation correction, Monte Carlo scatter correction, and resolution recovery. And I'll talk about those each in turn now. So I'm just taking a drink there. Okay, so first of all, CT attenuation correction. We use a bilinear conversion model to take the Hounsfield units that you see in the CT scan to map them to linear attenuation coefficient at 140 keV. From there, they are then further scaled to the attenuation coefficient that it would be for the energy of the radionuclide that you're using. This model is CT kV dependent, and we have the coefficients that you need for this. So we know those for all manufacturers of SPECT CT camera. So we can provide them to you to use in your reconstruction protocols, or you can measure them yourself if you wish to check that. Monte Carlo scatter correction. So Hermes use the Monte Carlo method for scatter correction, and we do not use energy window-based subtraction methods at any point. We think that this Monte Carlo scatter correction is better, is more accurate in all circumstances. So this is a challenging thing to do. It depends on several factors. The activity distribution inside the patient, the attenuation map, so that's the CT, so that's the two factors are patient dependent there. It depends on the camera energy resolution and on the energy window settings. Scatter inside the patient is simulated during the forward projection step of the iterative loop with the Monte Carlo modeling according to a convolution-based force detection algorithm. If you would like more information about this algorithm, I urge you to read the two references. So I've put a couple of references there, reference 1 and reference 2. If you would like more details about this algorithm, these are great references to check out, and I will put up the references list at the end of the presentation. Resolution recovery. So we have a Gaussian model of resolution recovery. So this accounts for image blur from both the intrinsic resolution of the gamma camera and the finite size of the collimator hold. So this is the well-known relationship that the further the patient gets away from the camera, the worse the resolution of the image. So this is modeled during the forward and back projection steps. We convolve the reconstruction voxel with the camera's point spread function before projection. That point spread function in this Gaussian model is calculated depending on the intrinsic camera resolution, the collimator hole length, the collimator hole diameter, and the distance to the front face of the detector. So those first 3 points there, again, Hermes can provide that information to you. We have that for all SPECT camera manufacturers. The distance to the front face of the detector, that's something that we find from the DICOM header. So I don't know if anyone has looked at the DICOM header of raw SPECT data, but you see a field where for every angle that the SPECT is acquired at, you see the distance from the center of rotation of the head at that point. So that's what we use to scale the Gaussian function of the point spread function during the reconstruction. So that method of doing resolution recovery is effective for well-collimated radionuclides. So technetium, for example, which is well behaved and is collimated well. But for other radionuclides, so things with higher energy emissions, such as I-123 or I-131, yttrium-90, the collimator does not do such a good job, and we have other interactions to consider. So we have a Monte Carlo model for the point spread function in these cases, So photon A is well collimated. Photon B is scattered off a collimator septum and then absorbed in the crystal. Photon C is absorbed by the collimator septa, and then a K-edge X-ray is emitted, which is then absorbed in the crystal, and photon D goes straight through the collimator. So the Monte Carlo model of point spread function for these isotopes takes all of these interactions into account, and it makes a much more accurate reconstruction for them. We have a nice paper here from a Finnish research group testing out this new algorithm. So this paper was out in 2018. So they looked here, it's a phantom study looking at 3 methods of scatter and collimator correction for I123 and I131. So we have the Gaussian model, so that's what we used for technetium. The triple energy window method, which is probably the most sort of clinically used, or other than the Monte Carlo, so that's often what other reconstruction engines use as an energy window based, and it's triple energy window for I123, I131. And then we also have the new full Monte Carlo treatment of the collimator interactions. And you can see both from the graphs there and the phantom images, the recovery coefficient, which is the amount of activity that we measure to be in the image compared with what we know should be there from the phantom study or from the phantom preparation. It's better for the Monte Carlo method than for both of the other methods. So this is a good result for our algorithm. A sip of water there. Okay, so, but you might say, doesn't resolution recovery cause artifacts in the image? What about these Gibbs-like ringing artifacts that you see, especially for the hot spheres in a cold phantom setup? So yes, that can happen, and this happens because resolution recovery tries to recover the fine details lost due to low spatial resolution, but that correction is not perfect, and if it hits a high contrast edge in the nuclear medicine, you can get these over and undershoots. So you can see there in the images, the 2 arrows indicate where you've got this kind of ring and then a lower area in the middle that has been caused by this resolution recovery. And this is on OSEM reconstruction. So a way around this might be to use Bayesian penalty factors to help mitigate against these kind of artifacts. So Bayesian reconstruction methods can reduce these over and undershoots by favoring images with adjacent voxels that are close to each other. And so basically we apply these penalty factors as constraints to the reconstruction problem. So these can be quite effective at suppressing noise, but also they might be able to reduce these ringing artifacts, and that's the subject of the paper which I've quoted at the bottom there, and a lot of the images are from. They looked at whether you can reduce these artifacts. This image here is just showing how these penalty factors are included in the iterative loop in our software. So we've got the standard OSEM iterative algorithm in the dashed box, and then the Bayesian penalty factors are applied to the current image estimate. But then the question is, which Bayesian priors and weights do you use, and how strongly? So basically, how strong should this multiplication be in the image? So we can have a little look here at some options. Again, a lovely image from the paper. So on the left, we have standard OSEM with no resolution recovery. The arrow in this image indicates where there is a missing sphere in the phantom. And then underneath that, we see the idealized profile of the largest sphere in the light gray and the measured profile on the nuclear medicine in the black. So then with the resolution recovery, we see the Gibbs-like artifact with the dip in the middle. And then the next 3 are different types of Bayesian prior and weight. So you can see there how they have slightly different fields to the image, and they recover the profile slightly differently each. And really the choice of which Bayesian option to use probably depends on what your reporting doctors would like to see and the kind of feel of the image, the kind of texture that it gives. So we've got a few examples here of how this looks on clinical data. The paper concludes that Bayesian reconstruction effectively reduces resolution recovery artifacts, but clinical acceptance is still lacking. So that was the case back in 2011. I think it's still true now. Okay, so having a look at what these corrections that we spoke about actually do to the image. So this is technetium cardiac phantom. And we can see in the top left image, we have no corrections applied. The top right, attenuation corrections applied. And so the effect to notice there is that the lungs are much less bright than they were than before. So because the density of the lungs is so low, that means that the counts from them are overrepresented in the image without attenuation correction. In the bottom left image, we have resolution recovery also applied. So we can see that the walls of the myocardium and the phantom are much better defined than they were in the previous one, they're much better resolved. And then lastly, in the bottom right, turning on the scatter correction portion, what to notice here is the fact that the counts inside the myocardium, so the dark area inside the heart there, which previously you could see some counts in, they were all scattered counts. There's no counts there really, and so they have been correctly removed there by the scatter correction. Okay, moving on to some practical considerations. Sorry, another drink. Okay, so sensitivity calibration. So once we are happy with the activity distribution of our reconstruction, then we can apply a sensitivity factor. So the way that we recommend to do this is to use a uniform phantom, scan it with the same camera, collimator, radionuclide, and reconstruction protocol that you're going to use on your patients. And from that, we can measure a sensitivity factor in counts per second per megabec, so CPS per megabec. And that sensitivity factor is then saved in your reconstruction protocol. And that can be applied every time you do that reconstruction. That gets your voxel values of your reconstructed SPECT into becquerels per mil. We recommend that you repeat this measurement every 3 to 6 months, or after a camera service, or after uniformity mapping, just as you would do for a PET SUV phantom calibration. Okay, and the last step, so voxel values are in becquerels per mil. Further, if we want to get voxel values into SUV, we need to have details of the injection activity and the patient weight and or height for the last step of the SUV calculation. So to do the SUV body weight normalization, so the SUV body weight is probably the most generally used in PET anyway. The underlying assumption in that is that the injection activity is uniformly distributed over the entire patient. Now, anyone who has looked at an FDG image will say that is not true. It's particularly not the case where you have a very large patient with lots of white fat. The white fat does not take up much FDG. So this leads to the quite well-known problem where you have the internal organs of larger patients looking hotter than they should do, because this scaling is making them look hotter than they should do. It's over-scaling in these cases because this body weight is not correct as an assumption. So other assumptions or other scaling factors have been tried. So we've tried lean body mass. That assumes, which was reasonable from the previous argument, that the injection activity is uniformly spread over the lean mass. And the lean mass is calculated with a weight and height empirical formula. Or we can use the BSA to make the normalization, or the BMI. So that's the SUV part. And to make sure that we have the injection activity correct, either it's necessary to measure the residual or to make a regular audit of your average residual. So perhaps you would, on average, say that you have 10% activity left in the syringe after injection, and then you can subtract that from what you injected, so that you will so you can have an accurate measurement then of what was injected to make that ratio for the SUV calculation. Okay, so the application of that to standardization of multi-center trials. So another nice piece of work from the Finnish group. This group took a NEMA IEC Phantom and they casted it around 5 hospitals in Finland, looking at 8, I think, different cameras here. So they measured recovery coefficients on each one, and they found that quantitative SPECT is reproducible in a multi-center setting with a third party, so with the Hermes SUV SPECT reconstruction software. This Dutch group took this study a little further, so they not only looked at the Hermes SUV SPECT reconstruction, but they also used the manufacturer SPECT reconstructions as well in their study. And they found that the vendor-neutral reconstruction, so the Hermes reconstruction, reduced the variation in quantitation 2- or 3-fold. So it's one thing that is paramount to harmonize these SUV SPECT reconstructions between the sites if you're trying to do a multi-center trial where you're wanting quantitative SPECT as an output result. The same group has done another study that's quite similar to this, but using lutetium this time. This was a technetium study. So for lutetium, then the application is that if you're doing dosimetry in a multi-center setting, then it's obviously very important as a first step in the dosimetry chain to make sure that the quantitative SPECT is reproducible. So looking at clinical application diagnostic. So this could be a problem that you are presented with in your own hospital. So you have technetium bone SPECT CT follow-up here. So we're looking at this tumor in the sacrum. We've got a pre-scan and a post-scan, and the question is, has the tumor got hotter, has it got worse, or has it got colder and got better? So the problem here is that the bladder filling is so different on the two scans that it makes the comparison of them by eye very tricky. So in this, all we can do is make a relative scaling of the images where the images are scaled relative to their own hottest voxel. So when you have a hot bladder like that, that really drags up that scale on the right-hand side, so it makes it hard to make a comparison. So if anything here, it looks like the tumor has got hotter on the post. You can see it looks more black on the post, so it looks worse than the pre. But actually now, if we turn on the SUV scaling, so we have set the color bar here to 20 SUV for both scans. Actually, the opposite appears to be true, that the tumor has got slightly cooler on the post. There's less uptake on the post than on the pre. So using the SUV scaling here has actually reversed our impression of the scan. A study here is a really nice application of SUV SPECTs. Again, from Finland, they are way ahead in this regard. We're comparing SUVs between technetium bone scans and fluoride PET for bone metastases of breast and prostate cancer. So the images here we're looking for, we've got two patients, SPECT on the left-hand side and PET on the right-hand side for the two patients. And you can see just visually a nice correlation there between the images, and they find a strong correlation between SUVs for the SUV SPECT bone and for the fluoride PET. And they find that SPECT is an applicable tool for clinical quantification of bone metabolism in osseous metastases in breast and prostate cancer, which is great news for hospitals without access to a PET scanner or to the fluoride tracer for these patients. Another nice paper here. So this is a paper from the US, I think, from St. Jude Hospital in Tennessee. They did a really thorough study looking at many sources of variability in quantitation of I123 MIBG SPECT CT for pediatric neuroblastoma patients. So not only have they done, they've got phantom studies between two cameras, they have multiple patient studies that they've taken these normal values from. You can see in the top graph there on the right, you can see the range of normal values for normal tissue uptake. And they've also, there's a subset of their patients who were scanned on both cameras. So they have really nice treatment of inter and intra-patient variability of the SUVs. And they find that SUV SPECT in these patients can be a very useful tool to monitor the follow-up or to see the progression through the treatments. Okay, so clinical application to radionuclide therapy. So thanks to the Curie Hospital in Birmingham for these images, we've got 4 cycles here of post-lutetium dotatate therapy images. So each of these images was acquired 1 day after the therapy was administered. And we can see that the SUV SPECT reconstruction with all of the corrections was applied. We're able here then to set the same. So we've got up to 30 on the scale there of SUV. And then you get a nice visual comparison, knowing that you're comparing like for like between these patients to see, or between these different cycles of therapy to see any progress. And also there, I have plotted the SUV peak for the hottest tumor there going through these cycles. This paper, some nice work from the team in Oxford, looking at the Y90 Bremsstrahlung modeling that we have as part of the full Monte Carlo modeling. So I think the main thing for me in this paper is just how much better quality that Y90 Bremsstrahlung image is. That's the right-hand side image there. Normally, when I've looked at Y90 Bremsstrahlung images before, they've just been terrible. It's actually possible to see some definition there in the Y90 Bremsstrahlung, which is really promising. Again, good for people who don't have access to the PET scanner for these treatments. Okay, so let's move on to the application to voxel dosimetry. Thanks again to Birmingham for these images. So these are, rather than being from different cycles, these are two images taken after the same cycle of therapy. So the patient has had the lutetium dotatate administered on day 0. So that's the left-hand side images. And then they've been imaged again on day 1 day afterwards. And we can see the change in the uptake between the organs and the tumors by this comparison. But then we could further go on to do some dosimetry on this. So the voxel dosimetry application can take between 1 and 10 input SPECT images. So in this example, so in the pictures, we've got 4 SPECT CTs that have been acquired. So 1 hour post-injection, 24 hours, 74 hours, and 168 hours. So the first step is to acquire all these images, then perform the SUV SPECT reconstruction. We need at least 1 CT in all of this. It's possible in the program to make an alignment between the SPECT at each time point and the CT, but I believe that Birmingham have found that's actually quite tricky in many cases if the patient's positioning is not very accurate. So perhaps it's best to have a CT at each point. That's sort of an area of research right now. But once we've got the alignment done and we can do an SUV SPECT reconstruction at each time point, then we do the co-registration. So we co-register either nuclear medicine to nuclear medicine or CT to CT. At this point, we have then a time activity calculation for each voxel and Monte Carlo dose simulation. So we can imagine that we've got, so for this, we've got 4 SUV SPECT reconstructions that are all perfectly aligned. So we can trace the voxels through each one. We can make a cumulated activity calculation for each voxel, and then we do the dose simulation. The output result is a dose map, which looks quite a bit like the input SPECT. It has voxel units of gray, and then we're able to analyze that with volumes of interest and dose volume histograms. So a little bit more information on the voxel dosimetry algorithm. So the way it's doing the cumulated activity calculation is it's using a trapezium rule calculation. So very straightforward calculation there through the time points to get the cumulated activity in each voxel. Then we have this semi-Monte-Carlo method of dose simulation. So what that means is we're doing a simulation of the photons through the CT until they get to an energy of less than 15 keV, and then they're assumed to be absorbed in the voxel they end up in. That simulation, the interactions with the CT are sampled from the cross-section tables in this reference. So please check there if you'd like to know more. And again, the algorithm is described more in reference 13 if you'd like to see that. For electrons, we assume a local absorption. So that's just a multiplying factor for the electrons. So we assume they do not travel from out of the voxel that they were detected in. That assumption has been rigorously tested. So we have validated this algorithm for lutetium, and we compared it with Orlinda for kidney dosimetry. This is actually the subject of a PhD thesis. And we have, so the one of the reasons for doing the electrons just by multiplying factor is that the computational effort required to do the electron simulation full Monte Carlo is much longer than would be clinically acceptable. And the accuracy gain in including that Monte Carlo simulation of the electrons is very small. So that's why we've come out with this method as a compromise for the clinical scenario. Okay, summary, we have looked at the theory of quantitative SPECT. We've considered some practical issues. We've looked at the application to standardization of multi-center trials. We've seen some clinical applications for diagnostic and radionuclide therapy response monitoring. And then we had a brief look at the voxel dosimetry algorithms. A summary from the software side. So we've looked at the Hermes Hybrid Recon SUV SPECT software and discussed the CT attenuation correction method. What we didn't discuss was other attenuation correction methods for if the CT is not available. So we have a synthetic new map for doing lung AC where the CT is not required, the uniform, so the Chang correction for neurology, and also we're able to do a radionuclide transmission attenuation correction. We looked at Monte Carlo scatter correction. We discussed resolution recovery, both the Gaussian and the Monte Carlo models. And then we looked at some Bayesian penalty factors as well. What I didn't discuss is that this program is also able to make a reprojection. If it has an attenuation map, we can do a reprojection of the SPECT back to the planar images, if that would be useful to help with a transition between reporting planar images to SPECT images. Then we finished by looking at the Hermes voxel dosimetry software. This is the reference list. It's quite long and it's quite small, so I'll leave it here for a little bit, but the best thing to do if you'd like some more details is to check back on the recording and read it from there. Okay, thank you for listening. If you have some scientific questions or any feedback, you can email them to me. So that's my email address, helena.macmeekin@hermesmedical.com. We will take questions from the chat now. If you have more general questions about the Hermes product, or if you would like to schedule a demonstration, please email info@hermesmedical.com.